Thank you all for coming this evening, and for those who are on Zoom, we welcome you as well and glad that you're participating. I have to say, for the first day of summer, we are all in an excellent place. I feel that you are going to leave here this evening much more aware of shoulder and neck discomfort. And I think we've got two fantastic presenters who will be speaking this evening. So please, I know there will probably be opportunities for questions. We welcome them. Just ask if you wouldn't mind holding them to the end. And then we'll definitely have an open session both here. And for those who are on Zoom, you can type in your questions as well. So our first speaker tonight, excuse me as I turn this around, is Dr. Ahmadi, who is already at our podium. But he completed his medical schooling at the Tehran University of Medical Sciences and his residency at the University of Toronto Medical School. He then followed that up and completed his fellowship at Mayo Clinic in Rochester with an expertise in shoulder and elbow surgery. I'm sure you saw a little bit of frozen shoulder in Rochester, Minnesota. But anyway, bad joke. I'll keep my day job. But most recently, he served as director of elbow and shoulder surgery at the University of Arkansas. And he recently, about 2 years now, moved out here to California. He is with Memorial Orthopedic Surgical Group in Long Beach, and we're happy to have him here this evening. Our second speaker is Dr. Vu Lee. He as well completed his medical school, but at Ohio State I can't read my own writing, Ohio State School of Medicine, and his residency at UCI here, obviously in Irvine. He then went south to Florida, University of Miami, for his fellowship in adult and pediatric spine surgery. There, he also was mentored by a renowned surgeon, Dr. Frank Esmont, who is a well-known spine and neurosurgeon, and really had a great experience there. Dr. Lee is with Newport Care Medical Group, and they have offices both here in Long Beach and in Newport Beach, and he will then be up after Dr. Ahmadi. So with that, the olive branch is passed. Thank you, Dr. Ahmadi.
Okay, so the shoulder has two different motions, okay? One motion is coming from the shoulder blade, and one motion is coming from the joint by itself, okay? That's very important to know because I'm going to explain over next few slides why it is important. 2/3 of the motion of the shoulder is coming from the joint, and 1/3 of the motion comes from the shoulder blade, okay? That's very important to know. Why? So if you look at here, you can see this is the shoulder blade, moves on the chest, and then we have the shoulder joint. So 2/3 of the motion from the joint here, 1/3 from the motion of the shoulder blade. If your shoulder blade doesn't move, you're going to lose 1/3 of your motion. If your shoulder doesn't move, you're going to lose 2/3 of your motion. Okay, so shoulder blade is very important. Look at this person's anatomy. You see how much kyphosis this patient has, okay? So this is going to affect your shoulder blade. The shoulder blade, instead of being in a kind of almost upright position, right now is kind of completely tilted forward. So this patient, no matter what I do with the shoulder, I cannot fix the shoulder. So they need to see the spine surgeon before I can do anything with the shoulder, because this position of the shoulder blade by itself puts the patient's shoulder at the damage for rotator cuff and other issues. They get impingement, they get shoulder pain, they lose the motion, and I cannot do anything to fix it. Whatever I do is going to fail because the whole anatomy is completely, basically distorted. Okay, so the chance of having shoulder pain during your lifetime is about almost 70%. So 70% of people will eventually have shoulder pain. And out of those 70%, unfortunately, 70% of them are due to rotator cuff tear and rotator cuff problem. Why shoulder has such a high rate of problem? Because shoulder gives you the highest range of motion in the body. There is no joint in the body that moves as much as shoulder does. So the range of motion of the shoulder is huge. Because of that, it puts the shoulder at the position that it prone to more damage. Okay? So if we want to divide the cause of the shoulder problem, we can put something that happens inside the joint and something happens around the joint, okay? What happens inside the joint? You can have arthritis. you can have damage to the labrum. Labrum is a tissue around the socket that makes the shoulder stable, okay? You can have a broken bone. The top of the arm bone can die. You can have cancer, you can have infection, you can have frozen shoulder. This is everything that happens inside the shoulder. What about outside? You can have rotator cuff problem. It can be inflammation, it can be tear, it can be problem with your biceps, it can be something called impingement, and it can be inflammation, okay? So, when the patient comes and we want to see the patient, we want to see about the age, is very important because every age has its own different basically pathology. So rotator cuff, for example, tear is very rare in younger people unless it's traumatic. It mostly happens after age of 40 in older patients, for example. And in younger patients, it's very rare unless it's related to a sport activity or trauma. So the type of the job they have, overhead activity. If somebody who is, for example, electrician, plumber, or somebody who is supposed to do overhead work all day, they're more likely to have shoulder problem, okay? So trauma. So how long this has been going on, that's very important too. It makes a huge difference in terms of decision about doing a surgery or not. Location of the pain is important, what kind of pain, and the pain has been going on for a long time, if the pain radiates to the arm or not. So the shoulder pain doesn't go all the way to the finger. If somebody comes and they have a shoulder pain that goes all the way to the finger, probably it's not shoulder, or at least is something else plus shoulder, okay? So night pain is very common in shoulder, and I'm going to explain why. So I told you, rotator cuff muscles are supposed to push the arm down and push the top of the arm down and press it against the socket. If they're weak, they're torn, or for some reason they're not doing their job, this big muscle deltoid is going to pull the arm up. When you are basically in upright position, standing, the weight of the arm, the gravity helps to pull the arm down. When you are lying down, that gravity doesn't help you. That's why a lot of people with rotator cuff problem, they have night pain. They're miserable at nighttime. They have a lot of night pain. And during the daytime, sometimes they're happy, they're fine, they're doing okay. And sometimes they're smart enough to figure out that, hey, I started sleeping in a reclining position, and right now I'm fine. My pain at nighttime is gone. It's just because you are getting help from the gravity. Okay? So then we are going to talk about if they have stiffness, they have the grinding, weakness, tingling, and numbness, or pain. So then we go to the physical exam. On physical exam, there are a few things that can help us to see what's happening. For example, here you can see there is an atrophy of the muscle here, this area. So that means that patient has supraspinatus and infraspinatus tear, for example. This is the long head of the biceps torn. It's called Popeye muscle. So there are a few things in the physical exam can help us to reach the diagnosis. So this is a patient, for example. This is an orthopedic called escape. So the patient is not able to raise the arm. This is pseudoparalysis, called pseudoparalysis. It's not real paralysis. It's not the nerve problem. It's a rotator cuff problem. They cannot lift the arm anymore. And you can see the arm is trying to escape from this space here. This is called escape. This is a really advanced stage of rotator cuff pathology. Okay, and then we go on physical exam. On physical exam, we check the different strength of the different muscles of rotator cuff and around the shoulder. And after that, X-ray. X-ray is going to help us to see a few things. If somebody has a fracture, there's a cancer, there is some arthritis going on. This is the top of the arm bone. This is the shoulder blade, and this is the top of the arm bone here. And there's a space in here, and this space is supposed to be at least 7 or more than 7. If this space is decreased, this is the area that your rotator cuff tendon is. If this space is decreased on the X-ray, it indirectly tells us that you have a rotator cuff tear. This is the bone spur. So you have heard of a bone spur probably. The bone spur is, there is a ligament in here, and this ligament over time gets calcified as we get older and acts like a spur. So this is what we call bone spur. So bone spur by itself doesn't mean anything. So a lot of people come and say, hey, I have a bone spur. The bone spur by itself is not the problem. The bone spur becomes a problem when you have a rotator cuff problem. So in the past, about maybe 20, 30 years ago, they were thinking that the bone spur is a big deal. We have to remove them. They were doing a very aggressive operation to remove this. But right now, we know that that's not an issue anymore. Okay, so then when we basically suspect any rotator cuff tear or any other issues, and we want to get more imaging, the best imaging modality is MRI. So we get the MRI of the patient. MRI is very sensitive, very specific, shows a lot of detail about the tear, shows the size of the tear, the location of the tear, how much retraction is there, if the tendon is a good tendon for fixation, the tendon has a poor quality, the muscle has a poor quality. And as you can see here, rotator cuff tear is very common. I'm going to show you in a slide right now in a minute. So when you have a rotator cuff tendon tear, what happens to the tendon and to the muscle? So what's happening is when the muscle doesn't work because one side is not attached anymore, muscles start retracting and goes through a situation called atrophy. It shrinks over time because it's not working anymore. It gets smaller and smaller. And this is not reversible. Unfortunately, when you lose your muscle, you cannot train it back with physical therapy and restore the whole bulk of the muscle anymore. When it's gone, it's gone. So far, we do not have the ability to do that. We have done some study on this to reverse it. We did some study on rabbits, and it has been very successful, but it has not been on human so far. It has been done occasionally in human, but again, it's not been kind of popularized so far. The other thing happens is the muscle gets replaced by fat. You can see here, this is supposed to be a muscle like this, and you can see all of this white stuff inside the muscle is fat, and this one is not reversible either. And what happens is over time, when you have a rotator cuff tear, muscle replaces with fat, and also it shrinks and gets smaller. Unfortunately, it's not reversible anymore. So if somebody has a big rotator cuff tear, they're young, probably is not a good idea to wait too long, because when they get to this stage, then we cannot do much. Okay, so what about referred pain? Shoulder pain can be referred to the neck, and neck pain can go to the shoulder. This is a very common problem, and unfortunately is a very difficult issue for us, and sometimes it's very difficult to differentiate if this is the neck pain coming to the shoulder or shoulder pain go to the neck, or this is a combination. If it's a combination, is it 10% from the neck or 10% from the shoulder? You know, it's very important to know, because that defines if we need to treat the shoulder or the neck, because, you know, I told you, let me give you this example. If we go and find 100 people and they are 6 years old and they never had shoulder pain, never ever had shoulder pain, we bring them here, we get MRI from the shoulder, 50% of them will have rotator cuff tear. Rotator cuff tear is a wear and tear. As we get older, it happens to us. And a lot of time they're asymptomatic. They do not cause any pain, they do not cause any trouble, and they're there. So again, more than 50% of the people after the age of 60, they have a rotator cuff tear and they don't even know they have a tear. So that's why this becomes a problem, because now you have a patient comes with the shoulder pain and neck pain. You get the MRI of the neck, there is something going on in the neck. And then you get the MRI of the shoulder, there is a tear in your rotator cuff in the shoulder. And right now, the problem is that doesn't necessarily mean that the shoulder pain is coming from rotator cuff tear. You may do the shoulder surgery and the patient comes back in 3 months, they still have the pain, because that rotator cuff was not caused of the pain. The shoulder pain was coming from the neck. So that's why it's important to differentiate where the pain is coming from. So one of the things we do, this is not 100% actually helpful, but it is very helpful. There is no study has shown that how much helpful, but again, it's very helpful. So one of the things is we can do basically injection, selective injection in different parts of the shoulder. Wherever we think that is causing the pain, we can inject numbing medication plus minus steroid injection. You don't have to have the steroid as long as we put some numbing medication in that area. If your pain goes away completely, for example, then that shows me that the pain is coming from your shoulder. If your pain goes away about 50%, that shows me probably 50% of pain is from your shoulder, and maybe 50% is coming from the neck. Again, this is not 100% accurate, but it's very helpful in the situation that you have both neck and shoulder problem, and we are trying to figure out which one is causing the problem. Okay, so this is a rotator cuff tear. This is exactly what happens. You see, this is the shoulder from the front. This is the muscle at the front of the shoulder, the tendon attached to the bone. This is the one at the top. This is the most common area of the tear. The one at the top of the shoulder is prone to tear, and this is the most common of the tear in your rotator cuff tendon. Okay, so what's consistent with rotator cuff problem? As I said, usually it doesn't happen in young people. So it usually happens after age of 40. Usually happens with the overhead activity. They have pain with raising the arm. They have night pain. They may have some atrophy on physical exam. They have a painful arc of motion during the physical exam. They may have some crepitus and clicking. They can lose the motion. They can have impingement sign. What is not consistent? If you don't have any arm pain, if you don't have any weakness, you don't have any impingement, you are very young, this is unlikely to be a rotator cuff problem. Probably something else is happening in the shoulder. Any questions so far? Okay, so I explained to you, this is the rotator cuff. Rotator cuff is supposed to push the arm bone against the socket and hold it here and prevent it from going up. Deltoid is a big muscle on the side of the shoulder, and this muscle constantly trying to push the arm up. When this becomes weak, either due to inflammation, due to some damage to a tear, or any reason, if this becomes weak, this is strong, is going to pull the arm up. And what happens is, this bone spur we have here, or the bone we have here, start hitting this area of rotator cuff tendon. That's called impingement. And again, during the night time, when the gravity is not helping you, that pain gets worse. Okay. This is the study I was going to show you. So you can see after the age of 60, you can see you have more than 50%, almost like more than 60% even chance of having shoulder pain. Rotator cuff tear, and you don't even know you have a tear. So how we treat rotator cuff? So the first line of treatment, unless it's acute, okay? So if somebody has a rotator cuff during a trauma, they had a bike accident, motorcycle accident, car accident, they fell or something, that rotator cuff happened during the fall right now, that's a different story. That one we want to repair them as soon as possible. Usually the best result happens within 3 months after the accident. The one that is chronic is they behave differently. That one we can drag it. So what we can do is we can start with physical therapy, we can do some activity modification, some anti-inflammatory medication like ibuprofen, start physical therapy, steroid injection, and see if the pain improves. If it improves, good for you. If not, then you're gonna need operation. This is what happens in the operating room. This is what we see. This is a tear. This edge of the tendon is supposed to be attached to the bone in here, and you can see it's torn and retracted. There is a different, this is called full thickness tear, okay? The whole tendon is completely torn and retracted. We have a different kind of tear, and this is the one that is more common, and a lot of people can have it without having pain. It's called partial tear. Partial tear can happen inside the tendon, can happen in the articular, basically the articular side, the inside of the tendon this way, not between like inside the body of the tendon, and it can happen on the outside. This is the most common one, the articular surface tear of the supraspinatus, the partial thickness tear, is the most common tear. So we do conservative management, physical therapy, injection, activity modification, ibuprofen, and eventually if they don't respond, the next step is operation. In the past, they used to do lots of open surgery. Right now, it's very rare for us to open the shoulder for rotator cuff repair. It's all arthroscopic procedure. We put something called suture anchor. It's either made from plastic or metal, has suture attached to it. We put in the bone, we pass the suture through the tendon and tie it back, and this is how it's going to look like after we fix it. Unfortunately, the healing process and the recovery for rotator cuff is not short. It's very long and very annoying because it can take you up to about 5 to 6 months. So the patient will be in a sling for about 6 weeks, then they start physical therapy with some range of motion. In about 12 weeks, we start the strengthening exercises, and it takes them probably around 5 months to recover from that tear, and depends on the size of the tear. If the tear is very big, it's going to be much longer. If the tear is small, it's going to be shorter recovery. So Massive rotator cuff tear, what it means is if you have at least 2 tendon tear with significant retraction, it's called massive rotator cuff tear. Those are different because number one, massive rotator cuff tear is less likely to heal. Even if we fix it, the chance of the healing is less than a small tear. The other problem with the massive rotator cuff tear is sometimes it's not fixable. I told you, if you have a massive tear that you wait for a long time, the tendon gets retracted and eventually becomes so retracted that you cannot put it back on the bone anymore and you cannot fix it anymore. So what we do in this kind of situation, obviously a patient can have non-operative management. Sometimes we can repair just part of it. It's called partial repair, and they do fine. So sometimes we just do cleanup. Sometimes we use a tissue from a donor. So we fill the gap with the tissue from a donor, and it's, again, not going to be exactly like your own shoulder. It's not going to be ideal. It's a salvage procedure. It's better than nothing. So there's a new thing that there's a balloon actually we put inside the shoulder on top of the rotator cuff tendon. It works very good. It's new. We have about few years follow-up. We don't know what's going to happen long term, but few years follow-up shows good result, but it doesn't last very long, and eventually it dissolves. We can do tendon transfer. Shoulder fusion, not a great option. You're going to lose your motion, and eventually we can do something called reverse shoulder arthroplasty. If somebody has massive tear that is not repairable, and they're 60 or 60 plus years old, shoulder arthroplasty is a great option and works great. The success rate is very, very high. So before we go to the next one, if you guys have any question or... Yes? So we usually do every 3 months, but again, if you are getting it every 3 months and for a long time, that's not a good option. That means that probably, if you get like 2 injections and it doesn't work anymore, then you should think about the operation. The one I do it for life are the one who are very old. They cannot have surgery because of the other medical issues, and those are the ones that we don't push for the surgery. But if somebody was younger, more active person, and they already had 1 or 2 shots and they're not responding, probably they should talk about doing an operation. Okay, let's talk about shoulder instability. Okay, the shoulder instability is more common and more problematic in younger people, not older people population. So it can be to the front of the shoulder or it can be to the back of the shoulder. Obviously, this is more common than this one. So in younger patient, I mean patient in their 20s and their 30s, when they have a rotator cuff, when they have a shoulder dislocation, the main concern for them is shoulder instability and recurrence of dislocation. They can dislocate again. That's a problem. But what happens is, as you can see here, after basically age of 50, the chance of having a rotator cuff tear is very high. So what happens is you dislocate your shoulder when you are 50 or 60. I am not concerned about redislocation again. I am concerned about rotator cuff tear. And it's very, very common to have a rotator cuff tear. Unfortunately, when you have shoulder dislocation, you come to the office, it's very difficult to see if you have a tear or not. Because of the pain, the examination is difficult. What we do is we follow the patient, we see the patient after they recover from the pain of dislocation to see if they have a tear or not. And if we suspect the tear, we do MRI of the shoulder. So that's why it's very important, if you have a shoulder dislocation, you need to see your physician after a few weeks when the pain is gone to make sure you don't have a rotator cuff tear. Because again, it's a very, very common problem, and it's very common to miss that one because they see the patient for 1 to 2 weeks and they're gone. Okay, so we immobilize the shoulder for shoulder dislocation. In young people, we do it for 2 weeks. As people get older, we do it for 1 week because they can get a stiff. Again, the shoulder redislocation is not a concern for older population. So what about shoulder arthritis? So there are several reasons for arthritis. You can have rheumatoid arthritis. It can be basically from head dying, from basically instability, from rotator cuff tear. There are so many different reasons for arthritis, but the most common one is the primary arthritis, that basically wear and tear that happens by aging. So it's mostly more common in male. It happens mostly after the age of 65, but there are some young people come with arthritis too. Usually those are post-traumatic due to trauma or athletic injury, or they are weightlifter. They can have shoulder arthritis. So this is a classification for us. The reason I put this classification is, what happens is when you lose your cartilage in the shoulder, then you have bone on bone. And when you have bone on bone, it acts like a sandpaper, and it just kind of grinds on top of each other, and that's a problem. So over time, the bone grinds the other bone, and you're going to lose lots of bone on the socket side. Losing bone on the arm side is not a problem. Losing the bone on the socket side is a problem because eventually you end up with this biconcave or something like this. That's going to change the operation. All of a sudden, from getting regular shoulder arthroplasty, you need to get a reverse shoulder arthroplasty, sometimes with even custom-made implant. And also, if we do regular shoulder arthroplasty in the B2 glenoid, the survival of that shoulder arthroplasty is less compared to somebody who has this kind of shoulder, for example. So that's why if somebody has shoulder arthritis, they don't want to have an operation. Not a bad idea. Once in a while, they should get an x-ray of the shoulder, make sure they don't have significant erosion of the socket. I'm not telling you every year, but maybe one or every other year. Okay, so the first line of treatment, activity modification, same thing, NSAID, physical therapy, and a steroid injection. If it doesn't work, there's option for surgery. If somebody has mild arthritis and the arthritis is not too bad, sometimes we can do just arthroscopy, put the camera inside the shoulder, clean up the shoulder, clean up all of the loose pieces and basically torn cartilage, and give them more time to get to this arthroplasty part, okay? When we do arthroplasty, there are several kinds of arthroplasty. One of them is hemiarthroplasty. Hemiarthroplasty means half replacement. We put something on the arm side, but we don't put anything on the socket side. This one is anatomic arthroplasty, and this is reverse. This is complete replacement, okay? So reverse shoulder arthroplasty is designed for somebody who has a rotator cuff tear plus arthritis, and this one is for somebody who has intact rotator cuff tendon. So the anatomic one gives you better range of motion and better strength compared to reverse, but both of them a great option. Unfortunately, that's not going to be your choice. It's going to depend on your rotator cuff tendon status and also your bony status. Hemiarthroplasty is a good option for younger people who want to be active. After complete replacement, we usually tell the patient not to lift heavy stuff. Nobody knows the exact number. Somebody tells the patient 20 pounds, 30 pounds, this is all over. But the idea is you're not supposed to lift anything heavy because the socket is the weak link of shoulder arthroplasty. If you put too much force on the socket is going to get loose. But with the hemiarthroplasty, I had a patient who was lifting. He was a weightlifter, had a proximal humerus fracture. We did the hemiarthroplasty. He was lifting 400 pounds. There's no limitation. You can do it. But the problem with the hemiarthroplasty is it doesn't last very long because you are having a metal rubbing on the bone, and it kind of keeps eroding the bone. And in about 5 to 10 years, the patient comes back with significant pain, and we have to revise it. Okay, so the operation is done through incision in front of the shoulder like this, and then we dislocate the shoulder, we cut the top of the bone, and we put this one for shoulder arthroplasty. If somebody has a great bone, this is called the stemless. It does not have anything down here compared to this one, and if the bone is not good enough, we do this one. And as you can see, this is the socket part that has a plastic, and sometimes we use the hybrid that has a piece of metal on it. And this is hemiarthroplasty. It means half replacement. This is complete replacement. You can see there is something on the socket. Here, there is nothing on the socket. So the other one is reverse shoulder arthroplasty. It's called reverse because the ball and socket are reversed. You can see the ball, instead of being on the arm bone, is on the socket, and the socket is on the arm bone. This is designed for somebody who has a rotator cuff tear. So the deltoid muscle is the main muscle that takes over and does the range of motion in this kind of shoulder. Let's talk about the fracture. So proximal humerus fracture, very, very common fracture. So this is one of the most common fracture: hip fracture, distal, the wrist fracture, and the shoulder fracture. Those are the three most common fractures that happens in elderlies. So what we do, the goal of treatment is not a good-looking x-ray. We are not looking for a perfect x-ray and perfect reduced bone. There are lots of studies showing that you don't have to have that. The idea is we need to do something to minimize the pain and maximize the function. That's why the treatment individualized. So you cannot come and tell me, hey, my neighbor had this fracture and they operated on that one, so I have to get surgery. No, you may not need the surgery. So everybody's different. So Treatment, about more than 70% of the time we treat them non-operatively. More than 70% of people do not need surgery for proximal humerus fracture. About 20-30% of the people, they need the operation. And the operation, there are several different operations, rod, plate, and sometimes we have to replace the shoulder because it's not fixable. This is, for example, was plate and screws. The next topic is a frozen shoulder. It's a very common problem, and you probably have seen it in family member or somebody else. What is frozen shoulder? So what happens is inflammation is start inside the shoulder, inside the capsule of the shoulder. We don't know why, and it causes inflammation, and inflammation becomes a scar, and the shoulder becomes a stiff, okay? And that stiffness causes pain and also limited range of motion. So it goes through different phases. The first phase is the inflammation, you have pain, and then you have a scar tissue, that shoulder freezes. And in some people, they go through the thawing process. Basically, what happens is they eventually get the motion back. But about 30-40% of the patient do not go through this, and they don't get the motion back, or it may take a very, very long time to get the motion back. So what happens is more common in female. In some of the problems, like somebody has diabetes, endocrine disease like thyroid problem. If somebody had the breast surgery, they had a CVA, they had a basically bypass surgery, any operation in this area can trigger the basically adhesive capsulitis or frozen shoulder, okay? If somebody has diabetes, the problem is they're less likely, the prognosis is worse. They're less likely to respond to treatment, and they're more likely to have the recurrence of the problem, unfortunately. So the main treatment for this one is physical therapy, home exercise. It's very painful to go through this. Unfortunately, there is no other option, and then a steroid injection can help. Eventually, after a few months, if they don't respond to that, they may need the operation. Sometimes the patient comes back and tell me, hey, my motion is better. The problem is they go through aggressive physical therapy. I told you 1/3 of the motion in your shoulder comes through the shoulder blade, not the shoulder joint by itself. When they go through the aggressive physical therapy, sometimes they get more motion to the shoulder blade. They come back and they say, hey, I have more motion. But when we hold the shoulder blade and examine the shoulder, we see that the shoulder motion has not really changed. Okay, so that's one of the problems. And basically, we look at the trend. If somebody comes and although they have a very slow recovery, then that means they're recovering, so we can wait. Somebody comes and in 3 months they have no improvement, then they can basically talk about doing an operation. When we do the surgery, there are two options. One of them is manipulation under anesthesia, and the other one is arthroscopic procedure and releasing the scar. Manipulation under anesthesia, basically we put you in a sleep and we push on your arm to get the motion back. That breaks the scar. The problem is breaking the scar with manipulation under anesthesia is uncontrolled. We don't know where the scar is going to break. So rarely you're going to have some damage to other part of the shoulder that we do not want. The other option is arthroscopic procedure. We see exactly where we are cutting, so we release the capsule 360 degrees and release your shoulder. Is more controlled and is a good option for treatment. It's outpatient, you go home and you start physical therapy. I'm going to say a few things about the elbow arthritis, and then I'm going to let Dr. Lee to take over. Okay, so elbow arthritis is getting less common because right now we have tons of medication for rheumatoid arthritis, and that's why it used to be one of the most common operations for rheumatoid arthritis, but again, because of the new medication, the rheumatoid arthritis is controlled very well, we don't see that much anymore. So the number of the elbow arthritis that's increasing is mostly post-traumatic right now from trauma, okay? So the elbow arthritis is different from the shoulder. So they're going to come with pain. Initially, they come with something called impingement pain. They don't have pain through the range of motion. They have pain when you bend the elbow at the end on both directions. And that's basically because they have extra bone around the elbow, and that causes impingement and causes pain. And then eventually, the arthritis advances, and you get pain through the range of motion as well. So why this is important? It is important because if you have early arthritis with some bone at the front and back that's causing impingement, we can put the camera there and remove all of this bone and help you. When it becomes advanced like this, then the arthroscopy doesn't work. You have to have elbow replacement. Okay, so I put a few questions probably a lot of you will have. So sometimes people can come and say, hey, am I too old for the shoulder surgery? The answer is no. So the shoulder surgery is about quality of life. And a lot of time it's easy for the patient to decide if they need the operation or not. It's not a difficult decision. They come and say, hey, I'm miserable. I can't do anything. My arm is useless. Anything I do is painful. At nighttime, I cannot sleep. That means you need the operation. Doesn't matter you're 82 or 90 or whatever. Have I done this operation in old people? No. I have done this operation in 96 years old. It's all about the quality of life because you want to have painless shoulder for the rest of your life. So, how long I can wait for the shoulder surgery? It depends, okay? So if you have a very big rotator cuff tear that is retracted, probably not a great idea to wait too long because at some point it becomes irreparable. If you have shoulder arthritis, what's going to happen? A lot of people come and say, hey, I have shoulder arthritis. Can I wait too long? The problem is, if you wait too long, you have other medical issues, your operation becomes more complicated. If you wait too long, you're going to lose more bone, you're going to have more damage to your shoulder. The type of the operation is going to change. So, what can I do for pain? So, there are tons of study on taking narcotics. Narcotics is going to be a big problem. If you take narcotics before the operation, the study has shown that the complication rate after the surgery is higher. The infection rate, failure rate, post-op pain, you're not going to get rid of the pain even after the operation. You're going to be having shoulder pain even after replacement. The result is poor. So if somebody is on chronic pain medication, they don't do very well even after the surgery. So it's better not to take narcotics. NSAID, like anti-inflammatory medication, is good. It's basically very safe if you don't have any kidney or stomach issue. Tylenol is a very safe medication, so you can try those. If you are taking too much narcotics for your shoulder pain, then probably you should have the operation because that narcotic is going to cause more problem. Is the surgery very painful? The surgery is painful like any other operation, but again, what we do is they do a nerve block before the operation. That usually gives you pain relief for about 1 to 3 days, and that's the period of time that the pain is really bad, and after that it's not too bad. Can I have both shoulders done at the same time? The answer is absolutely no, because there is no way anybody else can take care of you after having both arms in a sling. There is no way. It's going to be very, very difficult, so you don't want that. So they come and say, hey, my friend had this surgery and this was this and that. Everybody's different. You cannot compare yourself to your friend. Everybody's shoulder is different. Everybody's body is different. Everybody's pathology and shoulder problem is different from other person. Do I need help after the surgery? Depends. After the operation, you will be in a sling for a few weeks. Depends on the type of the surgery. For reverse, for example, 2 to 4 weeks. The other one, 6 weeks. So a few days after the surgery, probably you're going to need help. After that, you should be able to manage yourself. So a lot of people come and say, hey, I'm supposed to have my knee done. Should I have my knee done or my hip done? So the answer is most of the time shoulder. Why is that? It's not because shoulder is more important. It's because it's going to make your rehab easier. After the knee or hip surgery, you may need to use cane or you may need to use crutches. If you have a bad shoulder, that will go very, very, very difficult, and that's going to make your rehab complicated. So most of the time, it's easier to have your shoulder fixed and then your hip and knee. Okay, can I have vaccine before the operation? Yes, you can have any vaccine. The idea is no problem. The vaccine occasionally can cause inflammation around the shoulder if they inject it too deep. It's a very rare complication of the vaccine sometimes we see. So the safest thing is if you want to have the vaccine, no problem, have it on the contralateral shoulder, not the upright shoulder. Okay, sorry. Okay, very common question, PRP. The PRP, what is PRP? We take your blood, we spin it, and we use part of the blood that has more growth factor, more platelet in it, okay? And does it work? There are tons of study on PRP, and the results are all over. There are some studies showed that it doesn't work, some studies showed that it works great, and some study even showed that it's horrible, okay? The number of studies showed that it works actually, and there is some benefit is more. But it's controversial. We don't have a solid, basically, evidence that it works for sure. But there's some evidence that it works in people with tendinopathy, not complete tear. If you have a complete rotator cuff tear and you go to your surgeon and say, hey, I want to have PRP injection, you're wasting your money. It does not work. Okay, what about the stem cell? A stem cell, we are not there yet. All of the product out there, they do not have enough stem cell to help you guys. You're wasting your money. I brought a few papers here. I can put it there. If you want to go ahead and study, you're welcome to take a copy and study that one. A stem cell is not there to help you with arthritis, rotator cuff, or anything else. The concentration, the number of the stem cell on the product is not enough, and we do not have enough knowledge. We do not have enough basically experience with that. We don't have enough follow-up. There is no randomized study done on that one. Still, we do not know it works. So if you want to do it, you're wasting your money. It does not work yet. In 10 years maybe, but right now we do not have that technology. Okay. Any questions? Yes? No, you cannot remodel the bone. That does not happen. Remodeling of the bone happens in a very, very early stage when you are a child. After that, you cannot change the bone. It's not going to happen. With doing that, you're just stretching. And that's a good thing to do, like a stretch the shoulder.
For the frozen shoulder?
Correct.
It's okay.
Yes.
All right, thanks guys for coming in today. Thanks to Rose and Jackie for setting us up, and Memorial Care for inviting us here. So I'm Dr. Vu Lee. I'm a spine surgeon, an orthopedic spine surgeon. Today I'll be talking about neck pain. So this is background that Rose went over. Went to UCLA for undergrad, Ohio State for medical school, UCI for residency, and then Miami for a spine fellowship. So neck pain is very common. It happens up to about 80% of the population. So up to 80% of the population will somehow have neck pain during one or more periods of their lives. It happens more in females as opposed to males. Actually, what's interesting is that it happens more in high-income countries. And the reason for that might be due to the work that we do in high-income countries as opposed to low-income countries. A lot of us are sitting, we're looking at the computer, so that can create neck pain. Urban areas as opposed to rural areas, again, probably related to the type of work that we do. The risk of neck pain increases up to the age of about 50, and then the risk goes down. The reason for that is probably because above the age of 50, you kind of slow down with work, so the risk of neck pain is a little bit less. It's still there, but it's less. Neck pain can be pretty difficult to diagnose, as Dr. Ahmadi mentioned, especially if it involves the shoulder too. The reason for that is because you have multiple levels, and then you also have multiple structures around the neck that can cause neck pain, not just the discs and the nerves. Fortunately, for a lot of patients, up to 80 to 90% of the patients who have neck pain, a lot of times it'll go away within the first 3 months with conservative care. So neck pain can come from just more than just the discs and the nerves. It can be caused by stress, anxiety, depression. So in terms of work factors, people who sit a lot and do a lot of computer work, especially looking down, that can cause neck pain too. And then the musculoskeletal conditions that can cause neck pain, the most common is osteoarthritis or regular arthritis. And the two terms that are commonly used with regular arthritis is spondylosis, which is just a fancy medical term for arthritis, and then degenerative disc disease is part of the arthritic process. Inflammatory arthritis is not regular arthritis. It's related to rheumatoid, lupus, and other types of systemic inflammation of the body. Fibromyalgia is diffuse muscle pain, and that can the neck can be part of fibromyalgia in creating neck pain. So just a quick summary on the anatomy. With the spine, you have multiple levels. It's divided into 3 segments: the neck, the thoracic spine, which is the mid back, and then the lumbar spine, which is the lower back. Looking from the front to the back, it's supposed to be straight. Looking from the side view, you're supposed to have curves. Those are normal. Normally, you want to curve back in the lower back. You want to curve a little bit forward, but not too much in the mid back. And then you want to curve a little bit So when you look at the spine from the front to the back, if there's a curvature to the side, that's called scoliosis. Most of the time, scoliosis will happen in the mid-back and the lower back, not so much in the neck. Something that can happen in the neck is kyphosis, which is where you have excess curvature going forward. And you can see here, this is normal curvature. This is excess curvature going forward in the mid-back. That can happen in the neck where if it gets really severe, sometimes you can have a chin-on-chest deformity where a person cannot look straight and they have to look down at the ground forever. And those are the patients that usually will require surgery because they can't look straight. So this is an MRI of the neck. You can see here we have a lot of labels here. So there are a lot of structures here. And that's what makes it a little bit hard to diagnose neck pain sometimes because you do have a lot of structures and it's kind of hard to find out what's causing you your pain. So this is looking from the side view. This is the front, that's the back. This is your spine right here. And the boxes that you see, the gray boxes that you see are the bones. Not much happens to the bones unless you break the bones. Sometimes you can have bone spurs from arthritis. In between the boxes are the disc spaces. And that's where things happen. Just like tires, they wear out over time. Everybody will have some sort of wear and tear as they age. It's very common to see that. And when you have wear and tear on the disc, that's called degenerative disc disease. And fortunately, most of the time, it doesn't cause pain for a lot of people, but sometimes it can. And then in the middle of the spine, you have the spinal cord, and the spinal cord gives off nerves behind every disc to your arms. And those nerves will pass the shoulder. So that's the reason why sometimes when you have a pinched nerve in the neck, it can cause shoulder pain and arm pain. In the back, you have muscles, and that's the most common cause of neck pain, muscle pain. And typically, that doesn't need surgery. This is two x-rays showing normal x-rays here. Looking from the side view, typically you want to curve back a little. The boxes are here. The disc spaces, that's the space for the disc spaces, and those disc spaces are normal. And as you age, those discs will kind of wear out, and the spacing will get shorter. And then when that happens, when the disc wears out, it puts a little bit of stress or more stress on the joints in the back spine. That causes creation of bone spurs, and the beaks that you see here, those are the bone spurs in the front. You can't see the bone spurs on the x-rays in the back. Only the CAT scan or an MRI will be able to show you that. But it's very common when you have wear and tear, you're going to have worn out discs, you're going to have bone spurs, and the worn out discs and the bone spurs can cause the nerves to be pinched. This is two sets of MRIs. On the left-hand side, this is a normal MRI where the discs are white and healthy, meaning they're hydrated. And that's what you get when you're born. Unfortunately, as time goes on, these discs will have some wear and tear. You can see that they're dark here. And when they're dark, they can get squished, and part of it can get pushed back towards the spinal cord and the nerves. And fortunately, most of the time, even with that, a lot of patients don't have any issues or pain. And again, when you have worn out discs, we call it degenerative disc disease. And not everybody with degenerative disc disease will have pain. What can cause neck pain? So most of the time, a strain or a sprain, meaning stretching or overloading of the muscles, that's probably the most common cause of neck pain. And typically, you just have to stretch and prevent stiffness to make it better. Medications. We'll talk about the treatment plan. The most common cause of neck pain is degenerative changes or wear and tear over time, and like we talked about, the regular arthritis, which is osteoarthritis, causing degenerative disc disease, and facet arthritis, meaning arthritis in the joints of the back of the spine because of the increased stress on them due to the weak disc. Disc herniation is a subset of degenerative changes. In order to herniate or for that disc to be pushed back, it has to be weak. So it means that you have to have some sort of wear and tear in that disc to have a disc herniation. Fractures can cause pain. Spinal stenosis, which is narrowing of the space for the nerves, that can cause pain, especially when the nerve is being pinched. Inflammatory arthritis like rheumatoid, lupus. Infections can cause pain, but it's very rare that that happens in the neck. So when a patient first comes in, typically we'll see where the pain is. Neck pain will either present as just pain in the neck itself, which is pretty common, or pain going down the arm from a pinched nerve. That's not uncommon either. And sometimes it can be pain from the neck down just to the shoulder. And when the pain from the neck goes down to the shoulder only, sometimes that can be a little bit difficult to figure out if the neck is causing the pain or if the shoulder is causing the pain. And that's where you have to go to your doctor to see which one's the primary source of the pain. We check the range of motion. Typically, if you have pain, usually it'll be stiffer than usual. That's the reason why we recommend stretching to make it better. And then we'll do a neurological examination, especially for a patient who comes in with neck pain going down to the arm. When that happens, we always suspect that they might have a pinched nerve in the neck. And during the neurological examination, we'll check to see if they have any numbness or tingling. Typically, a nerve is responsible for one portion of the body or the arm. Each nerve has a special location in terms of the region that it supplies. So that'll allow us to figure out which nerve is involved, if they have any numbness or tingling in a particular region. We also check their strength. Each nerve is responsible for specific muscle groups. So if you have weakness in a specific muscle group, it will let us know which nerve is possibly involved. So this is a map of the innervation of each nerve in terms of each muscle group. So what happens if a patient comes in with neck pain going down to the shoulder? Again, we have to make sure that they don't have any shoulder issues. The reason for that is the reason why it's tricky to diagnose is because, as you can see here with this picture here, you have muscles spanning the neck and the shoulder, and so sometimes shoulder pain can cause neck pain, and then vice versa, like Dr. Armati said. That's where you have to go see a doctor to figure out where the primary source of your pain is. Typically, for a patient with shoulder pain, it'll hurt them to manipulate the shoulder or with shoulder movement. There are a few exams that we do, like the Hawkins or the Antican or the Jobs test to see if it's coming from the shoulder. And typically your doctor will do this to figure out if it's coming from the shoulder. If they're positive, then they will look at the shoulder first. A patient who has more of a neck issue as opposed to a shoulder issue will have a positive shoulder abduction test, meaning instead of hurting when they put their arm up, it actually helps them more. And the reason for that is because when the arm is being dangled, the nerve gets stretched and it gets irritated, especially if it's already pinched. So when you put your arm up above your head and the pain goes away, that's because the nerve, you're taking the slack out of the nerve. You're not pulling on the nerve anymore. So typically, one way to tell if it's coming from the neck as opposed to the shoulder is to do a shoulder abduction test, put their arm above their head, and usually it gets better if it's a neck issue as opposed to a shoulder issue. So other things that we look for would be atypical symptoms, and atypical symptoms would be associated with history of cancer, weight loss, drug use of steroids. So when they come with a history of cancer, sometimes they can have metastatic lesions in the spine that can cause pain. Weight loss, same thing. When someone says weight loss, we're worried about cancer. And drug use, we worried about an abscess or an infection. Steroids, we worry about a fracture because steroids can weaken the bones. Pain out of proportion, if the pain is excruciating and the imaging study doesn't explain it, that's pain out of proportion. Trauma, if you have any osteoporosis is if you have weak bones. We'll worry about fractures if you have a history of that. Fevers, if you have any fevers, we're worried about an infection. Bowel bladder dysfunction, we're worried about the spinal cord being pinched from various causes if you have any bowel bladder. So if you have any of these, we typically go to obtain the imaging study sooner than later as opposed to just sending them to physical therapy and waiting. We tend to look at or try to figure out the problem sooner than later. So in terms of imagings, we typically get an x-ray, and the x-rays will include flexion and extension views to look to see if they have any instability. That's the only way to tell if you have any instability. The MRI and the CAT scan actually aren't good for telling you if there's any instability. However, the x-rays will look at the bones and the alignment well, but it doesn't look at the soft tissue as well, and that's where you need an MRI. The MRI is good to look at soft tissue such as nerves, discs, muscles, tendons, cancer, infection. CAT scans are good to look at bones. Typically, if you're worried about a fracture, and that's the reason why if you go to ER and they're worried about a fracture, they always get a CAT scan as opposed to an MRI. Sometimes we'll get a special CAT scan called a CT monogram if a patient has had surgery and they have implants. Sometimes when you have implants, the MRI has a lot of artifact from the implant, so it's hard to see anything on the MRI, so you might have to do a CT monogram where they have to put dye into the sac of nerves. So what do we do when you guys come in with neck pain? Typically, we start off with conservative care, and the first thing is activity modification. The first thing that we normally tell patients is stretching. If you don't stretch, it's going to become stiffer and it's going to hurt more. So what you want to do is you want to stretch. When it comes to bed rest, you don't want to bed rest. Again, you want to avoid the stiffness. Avoid sitting down and looking down for a long time, especially with computers and phones when it comes to neck pain. Proper mechanics, so when you're working or sitting, just make sure you're looking at eye level and not looking down for a long time. Smoking is associated with neck pain and also back pain, so if they're smoking, we tell them not to smoke. And then in terms of heat, I'm a big proponent of heat as opposed to ice. For most patients, heat will help more than ice because heat will loosen up the muscles around the neck. There are some patients who prefer ice because it helps them more for some reason, because it decreases inflammation, but the problem with ice is that it can stiffen your neck, your muscles. So when it comes to heat, I normally say you can try a sauna, a jacuzzi, a hot tub, or a heating pad. Bracing, so a collar. Do you need a collar if you have neck pain? Typically, we don't recommend a collar. If it hurts really bad and it's hard for you to move, maybe we'll recommend a collar, but if you're gonna do a collar, don't put it on full time, 24 hours a day. The reason why is because it's gonna make it stiffer. So we rarely have to recommend a collar unless you have a fracture. In terms of medications, the most common medication is an anti-inflammatory medication that will help with inflammation and pain. And examples would be ibuprofen, naproxen, meloxicam. The problem with anti-inflammatory medications is that you have to watch out for side effects with the stomachs and the kidneys. So I normally ask if they have any stomach or kidney issues before I give them that. Another common medication is Tylenol. The problem with Tylenol is that it helps with the pain, but it doesn't really do much with the inflammation. So that's why we normally recommend an anti-inflammatory first. Narcotics, those are strong pain medications. Typically, we don't recommend that. The reason for that is because you can get addicted, you can get drowsy, and you can't do anything. Muscle relaxant, sometimes we give that if the pain's really bad, but the problem with that is that it makes you really drowsy. So typically if I give a muscle relaxant, I'll tell the patient to take it at night so it doesn't affect their daytime activities. A steroid pack is almost an anti-inflammatory medication, but multiply that by 5 to 10 times. For a patient who comes in with really severe pain, that's when we do a steroid pack for a few days. If a patient comes in with arm pain because of a pinched nerve, sometimes we'll give gabapentin or Lyrica. Those are good for nerve irritation. The problem with those is that it can cause drowsiness. Sometimes with gabapentin, it can cause a little bit of weight gain if you take it for a long time. So those are the medications. And then the next step is usually physical therapy. We'll send patients to physical therapy, even if they have a pinched nerve in the neck. A lot of times, therapy will sort that out and make it better. So during therapy, we normally recommend traction to stretch the neck. For patients who have pinched nerves, actually, sometimes traction will help because when you pull on the head, it actually creates a little bit more room, about a millimeter or so, for the nerve, and sometimes that can make it feel better. So when it comes to neck therapy, I normally include traction, and you can buy a traction apparatus on Amazon, and this is a common one. Some people ask about chiro and acupuncture. It's not really proven to work for everybody, but it doesn't hurt to try unless you have a fracture or a big disc herniation. Then I don't recommend chiro. But if it's just regular degenerative disc disease or muscular pain, then I'm okay with chiro and acupuncture as long as they're done right. So what happens if you still have pain after physical therapy? Then we talk about injections. There are 3 types of injections that we can do. One is a trigger point injection, which is an injection to the muscles, if you think it's due to the muscles. If you think it's coming from the joints in the back of the spine, you can do a facet joint injection. And we have an exam that we do to see if it's coming from those joints. And if you think it's coming from those joints, then you do a facet injection or a medial branch block. And typically we do that for just patients who just have neck pain without arm pain. And if you have arm pain because of a pinched nerve, typically we talk about an epidural injection or a selective nerve root block. Basically, you put that needle around that pinched nerve and inject some medications to calm down the inflammation associated with the pinched nerves. So what's in the injections? Typically, it's a combination of numbing medication with either steroids or lately we've been adding PRP. Like Dr. Ahmadi mentioned, PRP is relatively new. There are a lot of promising research showing PRP helps, but not for everybody. Steroids, there are different types of steroids, just different brands. The problem with steroids is that if you have too many of it, it weakens wherever it touches, bones, ligaments, muscles. So that's why we have a limit in terms of how many we can have. Typically, we say no more than 3 in a year. And if you need 3 every single year, especially if you have a pinched nerve, you should think about other options. Platelet-rich plasma is the PRP. So a trigger point injection is basically an injection into the muscles that are hurting, and you can do that with steroids or you can do it with PRP, either one. If you think the pain's coming from the facet joints, and typically if it's a facet issue or pain coming from the facet joints, typically it would just cause neck pain alone without any arm pain. If you have a facet injection or a medial branch block and it's short term only, but it helps more than 80% each time you have it, even though it's short term. Sometimes you can go to what we call radiofrequency ablation, which is when you burn the nerves in the back of the joints. Those are the nerves you don't need. The nerves going down to your arms you need, so we don't want to burn those nerves. If you have arm pain because of a pinched nerve, typically we'll mention an epidural injection. An epidural injection in the neck typically is done from the middle, where you put a needle in there into the epidural space, which is around the sac of nerves, and you inject the medication. So that can be done towards the midline, or it can be done from the side or transforaminal approach. Not a lot of people do transforaminal because of the structures that you have to go through. Very dangerous to go through those structures in the neck. So just a quick summary about how the injection is performed. Typically, it takes about 5 to 10 minutes. You can do it awake or asleep. Most patients can do it awake. We use numbing medication to inject the skin above that area, and then we'll use an X-ray machine to know where we're going with the needle. Once we're in the right location, we inject the medication in there, and typically it's a steroid. The most common side effects would be soreness around the needle, but just like the vaccine or the flu shot, sometimes you get it, sometimes you don't. If you get it, don't freak out. It might make it look like you have more pain after the injection, but it's just a soreness from the needle, but it goes away. Sometimes a little bit of headache, but it goes away too. So what happens if you have pain after the injection? Then we might have to talk about surgery, but not everybody qualifies for surgery. So there are 3 things that we can do for spine surgery. One is if you have a pinched nerve that's causing arm pain, we can unpinch it or decompress that nerve. And the medical term that we use when a pinched nerve is causing arm pain is radiculopathy. So if you have a pinched nerve and it causes arm pain, we can unpinch that nerve. We can stabilize any instability, and that can be due to a fracture, or that can be due to, there's a medical term called spondylolisthesis, where there's instability from just over time. And normally we can see that on imaging. And then we can fix deformities, such as the chin on chest deformity, which is an example of kyphosis. So we can decompress, meaning take the pressure off of the pinched nerve. We can stabilize any instability. We can fix deformities. But you can see that nowhere on here says we operate on just neck pain without any pinched nerves, without any instability, without any deformity. So that's the reason why not everybody qualifies for neck surgery. So my indications for neck surgery, typically you have to have tried conservative care. It's affecting your life, and they have to have some sort of arm pain. And the reason for that is because in order for us to successfully help you, if you have any arm pain, we can trace it back to a particular level. If you don't have any arm pain, it's going to be hard for us to figure out which level is creating the pain. So that's the reason why typically patients who undergo surgery will have arm pain in addition to neck pain. I rarely do surgery for just neck pain alone, and the reason is because there are a lot of sources that can cause neck pain, and sometimes we're just guessing if we're doing surgery on just neck pain. The only time I do surgery for just neck pain alone is if they have a fracture, if they have a tumor, or kyphosis, chin on chest deformity, or any instability. But most of the time, patients who qualify for surgery would be patients who have arm pain in addition to neck pain, not just neck pain, because they don't do that well. Examples of decompression surgeries, that's when we unpinch the pinched nerves. There are a few terms that we use. The first 2 terms are terms that we use in the back of the neck. One is called laminotomy, which is when we take a small portion of the bone out to create a little bit more room for the nerves, especially if they have just one-sided symptoms. Laminectomy is when you have to take out more of the bone, and that's when they have pinched nerves on both sides, and especially if they have multiple levels. In the neck, discectomy can be performed, but typically it's done from the front as opposed to the back. Doing it from the back can be done, but it's kind of dangerous because you have to move the spinal cord aside to get to the disc, and you don't want to manipulate the spinal cord. It's different from the lower back where we could do that, and with the lower back, we typically go in from the back, but with the neck, if we're going to do discectomy, we typically do it from the front because we don't have to manipulate the spinal cord. You don't want to touch the spinal cord because that will irritate the spinal cord and can cause paralysis. So an example of a laminotomy from the back is a removal of a small portion of the bone, especially if they have one-sided symptoms or if the nerve is being pinched on one side only. We shave off some bone to create more room for the nerves. The disc is in the front, so the disc is in front of the spinal cord and the nerves. And as you can see, if you want to go after the disc, you have to move the spinal cord aside, and you don't want to do that. You don't want to manipulate the spinal cord. So that's the reason why we typically prefer going from the front if we're going to go after the disc when it comes to the neck. The lower back is a separate issue. Here is an example of a laminectomy, which is removing a lot of the bone to create more room for the spinal cord and the nerves from the back. Typically, we'll save that for if you have pinched nerves at multiple levels. We typically go in from the back. Typically, if it's 4 or more levels, we go in from the back. We prefer to go in from the back. If it's 4 or less levels, we typically prefer to go in from the front. And another reason for the front is because you have less muscles here compared to the back, so it hurts less. And the incisions are smaller too, going in from the front. So when it comes to the neck, we prefer to go in from the front if possible. If not, then we'll have to go in the back. Discectomy. So with the neck, we typically prefer to go in from the front to take the disc out so that it's not pinching on the nerve anymore. But when you do that, when you take the disc out, you have to put something back in there, and typically we have to put implants back in there. And one option is a fusion, when we put an implant plus screws, plus or minus a plate. The other option is a disc replacement, an implant without screws. And we'll talk about who's a candidate for a disc replacement pretty soon. So stabilization, which is either a fusion or a disc replacement, like we mentioned, typically we go in from the front if it's 4 or less levels. We go in from the back if it's 4 or more levels. A fusion is basically when you stabilize that level by taking away the motion. It's just like a worn out tire. If you have any wear and tear, if you keep driving on it, if that car still has motion, it's going to continue to have wear and tear. So if you take away the motion, if you leave the car there and it doesn't move, then you're not going to have any more wear and tear. So that's the point of the fusion, to take away the motion there. And typically that involves screws and rods and plus or minus plates. And this is actually an example of going in from the front with one of my patients. This is a patient who had one level issue, and you can see that the incision is about an inch or so. This is an example of a patient who had a one level fusion because the disc was pushing on the nerve in the back here. So this is called an ACDF, an anterior cervical discectomy fusion. We'll take the disc out from the front. We'll put an implant in there and put screws in there to hold the implant together. This is a patient with 2 issues. One is pinched nerves at multiple levels, and then she also has kyphosis too, abnormal alignment of the spine. So we had to do multiple things. We had to take the disc out so that they're not pushing on the nerves, and then we also have to recreate the normal curvature so that the neck can tilt back. On top of that, we had to go in the back too to remove some more bone to create more room for the nerves and add a little bit more curvature by taking out a little bit more bone. So this is a combination of multiple ACDFs, or anterior cervical discectomy fusion, with posterior laminectomy and fusion for a patient who has a condition like this. And then another example of what we do is disc replacement. And so if you have a pinched nerve or pinched nerves, you can go in from the front and you can take the disc out and you can put implants in there without putting screws in there. and that's called disc replacement. The upside to this is that it preserves motion. It doesn't take away the motion. Downside is that it can wear out, just like knee replacements and hip replacements. We just don't know how long this will last because it's relatively new in spine surgery. And when I say relatively new in spine surgery, I'm talking about the last 10 years. We still need to do some research to find out how long it's going to last. However, not everybody qualifies for a disc replacement because if you have any instability, doing a disc replacement is going to fail. If you have a lot of arthritis causing pain, if you continue to have motion and you have arthritis in the back, in the joints in the back here, and you still have motion, it's going to still cause pain. And so that's the reason why for patients who have a lot of arthritis, we tend to favor fusing it, taking away the motion, so that the motion is not causing continuous irritation on the joints anymore. So just in summary, neck pain sometimes can be difficult to diagnose. And the reason why is because you have so many structures involved. And because of that, sometimes it can be hard to treat because if you can't find a reason for the pain, it can be hard to treat if there's no diagnosis. But most of the time, regardless of what it is, for most patients, it resolves within 3 months with conservative care. In terms of patients who need surgery, like I mentioned, a lot of times patients who come in with just neck pain alone, we normally don't bring up surgery. But if they have arm pain on top of neck pain and they've tried conservative treatment, sometimes surgery is brought up. And that's the end of my presentation.
Thank you very much. So you guys, this is your time. Dr. Mahdi, if you don't mind coming up to the front. But if people have questions, this is your time. You have two experts who've just really kind of enlightened us all in this area. And we'd love to hear from you. Gentlemen, if you don't mind, as people ask questions, if you wouldn't mind just repeating it so our guests who are on Zoom will hear it as well.
Yes.
I was curious, you said when you fuse the neck, what kind of motion does it limit?
So when you fuse the neck, meaning you put an implant in there with screws, plus or minus a plate or a rod, it does take away the motion at that level. But keep in mind that you still have the other levels. So theoretically, each level is in charge of 5 to 7 degrees of motion. So if you, depending on how many levels you fuse, if you fuse just one level, most of the time you don't notice much of a difference after surgery. You might feel a little bit stiffer, but not a lot. It's not going to be significant. But if you fuse multiple levels, yes, you're going to feel very stiff, but you're not going to be a robot. You can still move because unless you fuse from the head down to the mid-back, you're still going to have some motion. So it depends on how many levels you fuse. The question is, can you do a laminectomy in the neck? So a laminectomy is very common in the lower back, and typically in the lower back, it's easier to go from the back because you have a lot of access to the nerves. In the neck, you could do a laminectomy, and typically we save that laminectomy for patients who have pinched nerves or pinched spinal cord at multiple levels. If it's just 1, 2, or even 3 levels, we prefer to go in from the front because it hurts less going in from the front. Because you can still do a decompression or create more room for the nerves by going in from the front with a smaller incision as opposed to a big incision in the back. And you don't have to go through as much muscles in the front compared to the back. So when it comes to a laminectomy in the neck, we normally reserve that for when you have stenosis or nerve pinching or spinal cord pinching at multiple levels. So the question is it bad to manipulate the neck? No. I typically mention you should stretch, you should massage, keep moving so it doesn't get stiff. So when it comes to manipulation, I'm all for it. The only time I'm against it is if you have a fracture or if you have a big disc herniation. We don't want you to crack or manipulate your neck. But usually, for a lot of patients, it actually helps them to do that. So do it. Unfortunately, so the question is, can we do surgery just to remove bone spurs, multiple bone spurs in the neck? That's the question? Yeah.
But also other places where bone grows and
Yeah. So the question is, can we remove bone spurs, especially if you have multiple bone spurs? So we normally don't do surgery just to remove bone spurs. We only reserve surgery for when that bone spur is pushing on a nerve and causing symptoms, especially arm pain when you have a pinched nerve. That's when we go after those bone spurs. But the other bone spurs that are not pinching on the nerves, we typically leave alone because the risks outweigh the benefits of removing bone spurs just for the sake of removing bone spurs. If we're doing that, then we have to do it for the entire body because you're going to have bone spurs throughout the body. So the question is, will you eventually need surgery with a pinched nerve? Not everybody. Actually, about 90% of the patients, even with pinched nerves, will do well with conservative care and not need surgery. Yeah, less than 10% will need surgery. Yes?
I do. So I give the patient the option. I basically, the question is if I do manipulation for shoulder stiffness for frozen shoulder or not. So yes, I talk to the patient, I give them the option. So some people prefer actually manipulation. They don't want the skin to be cut, the shoulder to be cut. So, and then I tell them the difference. If you look at the literature, there is no difference in terms of outcome. The complication rate has not been studied very well, to be honest with you, but that potentially can cause some damage to the shoulder if you do manipulation blindly versus doing arthroscopy. But eventually, I'll let the patient to decide.
Do you have a preference either way?
If it's my shoulder, I prefer arthroscopy because it's more kind of controlled doing release of the shoulder versus you can damage rotator cuff, you can break the bone, or you can do some damage to the shoulder. So personally, if I have a frozen shoulder, I need the operation, I prefer arthroscopy.
So the question is cracking and popping normal for degenerative disc disease? Yes, very common. If I get $1 for every time I hear that. So it's very common when you have arthritis. It involves the joints, and it's going to cause some rubbing, bone on bone, and that's going to cause some cracking and some popping. And it's okay to hear that. Typically, sometimes it helps for a patient to stretch and pop their neck to make it feel better. So I'm all for that. I'm normally okay to pop the neck if you want to pop it. Yes, so the question is, which pillow is the magic pillow to prevent neck pain? If I have the answer, I'll be on an infomercial, but I don't. So it varies. Everybody's different with pillows because it varies on body contour, your weight, so and then the firmness of the pillow. It's very hard to tell you which pillow is better for you or not. Normally I say you just got to try out different pillows.
So she's asking if medial deltoid pain is related to the muscle or nerve or something. So this is, the deltoid is on the lateral part of the shoulder. The most common presentation of the shoulder problem is pain like here. The patient comes and says, this is the pain right there. So any kind of pain in the shoulder, most of the time present with this area. So you cannot find this specific point of pain a lot of time and say, hey, the pathology is right under that point. No, that's not true. So there is a tissue around the shoulder called bursa. And that tissue basically involves, I'm going to show on Dr. Lee's shoulder, sorry. So it basically covers a huge area around the shoulder. Anything happens around the shoulder causes inflammation in that tissue. And that tissue causes general pain around the shoulder, and a lot of the time you can feel the pain in this area. So that doesn't mean that this is your deltoid that's causing the pain. It can be your rotator cuff causing the pain. Okay, so she's asking that if somebody has a labral tear and had it repaired, can the tear happen again? So labrum is a tissue that goes around the socket, and it's a circular tissue that goes 360 degrees around the shoulder. So you may have a tear on the top of the shoulder that repaired it, and right now you may have a tear in somewhere else. So that's number one. Number two, can you tear your labral tear again? Yes, you can damage it again. That's possible.
I've got 2 questions from our guests on Zoom. The first is, someone asks, is it true that pain usually comes from the top down? An example is, if you have arm pain, is it more likely connected to the cervical spine as opposed to leg pain coming from the lumbar spine?
Thank you for handing that off. So if you have pain that starts from the hand, sometimes it can shoot up to the shoulder or the neck, such as carpal tunnel. Sometimes you can have atypical symptoms where it starts from the fingers and it shoots up, but it's all carpal tunnel as opposed to the shoulder or the neck. But sometimes when you have a pinched nerve in the neck, it can start from the wrist or the hand and it goes up. It's not uncommon when you have pinched nerves for your symptoms, the location of your symptoms to change over time. It can be anywhere along that nerve, from the neck down to the arm. So it could be a possibility for that to happen.
Again, shoulder pain does not radiate to the hand. If somebody has hand pain, this is not from the shoulder.
Thank you. Another question is, someone on Zoom had an x-ray at their chiro office and found that their shoulder is not fully in the socket and there's calcification in there. Is there a name for that, and how would that be treated?
So if the shoulder is not in the socket, the first thing we need to know if this is shoulder subluxation or dislocation. So I don't know exactly what they mean by that one. If shoulder dislocated, that's a bad problem. That should not be dislocated. If somebody's shoulder dislocated, they need to be reduced as soon as possible. If it's a chronic dislocation, it can cause significant damage to the point that they're going to need a major operation. Depends on the age. It can be either reconstructive operation with the allograft versus replacement of the shoulder. So again, depends. Calcification is a different story. So there is something around the shoulder called calcific tendinosis. What happens is your body starts depositing some calcium in the ligament around the shoulder, and that causes significant inflammation and pain. Sometimes body can resorb that calcium deposit, sometimes they cannot. And sometimes even if they cannot resorb it, the pain can go away. Okay, so again, they're talking about 2 different things, and I need to see the x-ray to see what they're talking about, because subluxation around the shoulder can happen. If you have a massive rotator cuff tear, your shoulder can sublux superiorly. If you have other problems like deltoid problem, it can sublux inferiorly. If you have instability problem, it can sublux again. If you have a significant like subluxation or dislocation of the shoulder, that's extreme. That needs to be basically treated right away.
Okay. And then one last question from our Zoom guests. One of the guests is on workers' comp and has been for many years with success with monthly therapy and neck adjustments with traction, ultrasound, and vibration massages on full body. The individual finds that it's very beneficial without surgery. The question is, does their situation sound good as long as they keep movements on neck and shoulders with exercises?
The short answer is yes.
The
Keep
longer
moving.
answer?
The answer is keep moving, keep stretching, keep massaging, and then normally I would add some heat to it to loosen it up. But it sounds like what they're doing is in the right direction, so I would just keep doing it.
Anyone else in this room? Sir?
Dr. Mani, you mentioned grinding or clicking.
So clicking is very common in the shoulder. Anything from inflammation or some kind of impingement can cause it. Rotator cuff tear can cause it. Shoulder arthritis can cause it. Shoulder instability can cause it. There are a huge spectrum of the problem in the shoulder can cause it. It can be benign. It can be due to a big problem. So if you have a concern about that, you need to have your shoulder checked, because again, there's so many things can cause it. So the question is, if carrying something over your shoulder can cause shoulder damage, or doing something with your neck, moving it, can cause some damage, you know, the normal daily activity is not going to cause any significant damage. The wear and tear happens no matter what. If you don't do anything, it still is going to happen. So the most kind of thing that kind of exacerbate all of this thing is going to the extreme, yes. Carrying something super heavy, yes, of course can do it, but something regular on regular basis, no, it's not going to affect it. How heavy is the camera?
I don't know, maybe 5 pounds
It should not be a problem. 5-pound camera shouldn't be a problem.
At what point does it get kind of heavy like
So that depends on you. 5 pounds for somebody can be heavy, and 5 pounds for somebody else can be nothing. So somebody else, maybe 50 pounds is almost nothing. So it depends on the person.
If it is getting sore though, I'm pushing on something?
So if you are getting sore from that one, you are probably carrying too long or too much of that. So you need to do some strengthening exercise. Your shoulder's weak. So probably you're not fit for that, carrying that kind of weight. So again, depends on the person. There is no number that we can say that, hey, this is good for you or not. So it's individualized.
Okay, but I should be careful if I'm feeling pain.
You're not going to damage your rotator cuff or anything by putting anything heavy on your shoulder. That's not going to happen. Rotator cuff damage does not happen by putting something on your shoulder, because the force does not go to your rotator cuff, does not go to the shoulder. This is going to a trap muscle here. So basically, that's not going to do anything with your shoulder. You're going to have some muscle fatigue and pain from it, but you're not damaging your shoulder.
Okay, good.
So rotator cuff tear almost does not heal. There is a very, very small chance of a partial thickness tear healing, okay? A few percent. So full thickness tear does not heal. Partial thickness tear very rarely can heal. So if you have a big tear, so how physical therapy works? Physical therapy works by this mechanism. So basically what we are doing is we are strengthening the part that is not torn, and they compensate for the torn part. So the torn rotator cuff tear is not going to heal by itself. So the shoulder becomes stronger. Those exercises are meant to basically strengthen the part that is not torn, and that's going to pull the shoulder down again and decrease the impingement, and the pain goes away. And as soon as your shoulder becomes weak again, the pain is going to come back. That's why I suggest the patient, when they're done with physical therapy, it's good to continue those strengthening exercises for their life.
Anybody else?
Yeah, so they have done a study on glucosamine. So glucosamine was advertised that it's going to create cartilage. That's not true. Glucosamine is going to be something close to a Tylenol. So if you're paying extra money, you think that glucosamine is going to make cartilage, that's not true. Correct. So basically the bone gets shrunken by putting force to it. So if you go to the space, you come back with osteoporosis. So again, that's why exercise is good. And the more load you put on your body, actually, the stronger your bone is going to get, and depends. So if you just do lower extremity, obviously you're exercising your lower extremity. You're not doing much with the upper extremity. So if you want to do upper extremity, you have to do a bit of weight training with upper extremity too.
So the walking, does that cover everything?
The walking does not cover everything. This does not cover your shoulder, no.
So we have to do a full exercise.
Correct.
Weight training, walking.
Yes, that's good for both bone and also soft tissue, for your rotator cuff as well. So if you don't want rotator cuff problem, you have to do shoulder exercise.
So to expand upon that, you said weight training. Heavy weights or more repetitions with light weights?
So again, one of the most common for shoulder injury is overuse, especially in younger people. So I can tell you, in younger people, more than 70–80% of the time, shoulder pain is due to overuse. So because they don't know their limit. So everybody's different. So somebody starts with 2 pounds and then gradually go up. Somebody can start with 50 pounds and go up. So you have to know your basically body, you have to know how much you can handle. You start with the small weight, a small repetition, and then you have to just gradually increase that one. So if you go to the gym and you start doing heavy weight and you're not ready for that one, you're going to damage your shoulder. Both. All of them, yes. They're grouped of the muscle, and there is a specific exercise for a specific muscle. So basically, you have to go and find that which muscle actually, which exercise is for which muscle, and you have to do that. You cannot train just one muscle and ignore the other one, because then you're going to have imbalance around your shoulder. You have to train all of them.
Will it compress the spine, having weights on the shoulders?
Weight on the shoulder, what do you mean by
Weights
what?
on- Doing a squat with the weight on the shoulder?
Uh-huh. So again, it can, if you're talking about doing heavy weight, yes, it can compress your spine too. It can be heavy on your spine, correct.
Do you recommend then going to a physical therapist or seeing our physician to get a referral to a physical therapist to make the best determination based on our size and what our needs are?
Correct. So basically, every physical therapy is different. So it depends on the pathology, okay? So the physical therapy for shoulder instability is different from the physical therapy for basically rotator cuff. So if somebody has a scapular, like shoulder blade problem, the physical therapy is different. So it depends on what's happening with your shoulder. They're going to train different group of the muscles. So let me give you an example. Somebody, for example, dislocating shoulder to the front, okay? So if you rehab the shoulder, the muscle that causes more anterior force of the shoulder, you're going to make it worse. So you have to train the muscle that pushes the shoulder back. So that's why it depends on what happens. They have to customize the physical therapy for your specific problem. So there is not just one set of exercise for everything.
We're walking out a little bit more educated than we walked in. Thank you both so much for your
My pleasure.
information.
Thanks for coming.
Both of our speakers, their bios and their contact information are on the sheet. So I think if there's anything else that maybe it warrants seeing a specialist and or a referral as appropriate, but their contact information. And we have surveys. And I know that those guests who are on Zoom, you can fill them out as well. Please let us know what's working well, what's of interest, areas that we can grow on. We'd really appreciate it because our intention is to continue offering them and we want them to meet your needs. So please do that as well. As the evening comes to a close, Dr. Ahmadi's going to close it out for us.
One more, actually. I printed a paper on a stem cell. I brought a few copies there. If somebody's interested in that one, you can go ahead and read about the stem cell.